What I'd like to do is share with you some ideas about arthroplasty. Who has experience in cervical arthroplasty? Okay, how about lumbar? All right, who has terrible experience with lumbar arthroplasty? All right, so I'd like to share with you a little bit about both. I've been involved in running some of the FDA clinical trials for a while. There we go. So I want you to kind of think, first we'll talk about lumbar and then I'll move to cervical because I think cervical is clearly much more common. And I want you to think upon, is it another product, like when we go and look at products today, or is it a completely different philosophy that you may have available on how you manage patients with degenerative disease? It's always a debate upon which of these products is best. And I've been in practice for almost 30 years, and we went from everything from threaded cages to metal cages to PEEK cages to bone to different approaches to access things. And now I think the same debate is which of these, if any, is the best way to manage a patient with a degenerative disease at a very specific phase of their disease. A lot of the heroic things that you've seen today are on how to manage multi-level deformities, sagittal alignment, large constructs. Those are primarily in patients that are much further along in their advanced disease, and I'm going to share with you. I tend to think of spine disease like dental disease, and you need different treatments for different phases of the disease. And this is one particular phase of the disease that we can take a look at. The takeaway message is disc arthroplasty is not another product. It's really a whole different philosophy on the way we manage disease. It's not just putting in something that moves when you normally would do the same operation to do something as a fusion. Now, we clearly know that there are cases where patients have instability and what they need is stability, such as a case like this with a pars defect and hypermobility, and patients like this tend to do well with a fusion. The problem with some of the literature in degenerative disease for fusion is very simple. The primary measure of outcome historically has been fusion, the success rate of a fusion. But we learned a lot more upon managing degenerative disease when we ran all these FDA clinical trials for arthroplasty because the primary measure of success is function. It's not fusion. So it changed the bar completely. And most people, if you would ask them what their success rate is for an ACDNF, they're going to tell you 95%, maybe 92, 97. Then how come all the FDA clinical trials showed you the overall success is 65? Because you are measuring fusion. And now we learned from the clinical trials that the primary measure of outcome is function. And so we're changing what we really look at. And if you're not doing the Oswestry Disability Index and the Neck Disability Index to look at function in the patient, you're really measuring the wrong outcome. And we'll talk a little bit about that. Because this is what happened. When you look at some of these studies from a decade or two ago of different ways that we can do fusion, everyone reported the fusion rate in these clinical trials is high. But the reality is the function rate, whether it was return to employment, patient satisfaction, narcotic usage, is always about 2/3. So we really haven't improved with all of these techniques our functional improvement in patients with degenerative disease. And I think that's really the benefit, because when you take, well, my slides are off by one. When you take a look at arthroplasty, I think the primary goal of arthroplasty is to give the patient the ability to maintain the motion. Disc replacements don't create motion. They maintain motion. And when patients show me x-rays of a disc replacement that's been in the lumbar spine and it's still stiff and doesn't move, I bet you never got it to move on the table. That's the key. I've done almost 1,000 lumbar disc replacements, and the motion and the remobilization is really the hardest part. Now, we've seen a lot of different arthroplasties and technologies in the last decade and a half, but what I find very interesting in North America, of all of these particular technologies, there's only 2 on the market in the United States. The ProDisc and the Active L are the only 2 arthroplasty technologies that are on the market. I've been involved in putting many of these in. They went through clinical trials. They spent millions of dollars, either material, design, non-inferiority. Not all of them ever hit the market. Let's take a look at this patient. This is a 52-year-old patient, 6-year history of disc resorptive syndrome, low back pain, degenerative disease, no previous surgery. Miserable, alters his life. Patients live in Colorado because, like a lot of areas, they want to mountain bike, they want to hike, they want to do things. This guy wants to play golf. Most people would probably do a fusion on this patient. He, for some reason, didn't really want a fusion. We remobilized this. I put an arthroplasty in this patient almost 8 years ago. He did have some facet pain and have a rhizotomy, but it's met his functional needs. Low VAS, back to work to do a variety of things. How about this person? This is a 49-year-old female that has had 3 lumbar disc extrusions and decompressions. This is her 3rd time. third time disc extrusion, has back pain and leg pain. And what are you going to do? Take another fragment out, which is very possible because she's done reasonably well with the first two. Are you going to do a fusion? Are you going to realize that the annulus and the motion segment's incompetent? So we're dealing with function. I approach these from the front. You can pull this big fragment out from the front. And we do most of these at the surgery center with just an overnight stay. And we put an arthroplasty in. I think the patient should be happy. Within 4 weeks, instead of a fusion, she went back to her activities. And the only thing she's pissed off about is the incision. And so she tells us that every time she comes in. So you're meeting functional needs of the patient, but sometimes you just don't always, for degenerative disease, meet all of their needs. How about this guy? 39-year-old dentist. Dentists sit all day, like hand surgeons. He has terrible back pain. He's tried physical therapy, a variety of anti-inflammatories, a number of injections, and he's miserable. 2-level degenerative disease that's really altering his life. Are you going to fuse him and fix his lumbosacral joint in a position and let him sit the rest of his career? He's got this change in one level. What would you do? So when this guy, would you tell him to live with it? Would you do a decompression? Would you do a fusion? What are you going to decompress? Are you going to do a front fusion, a back fusion we've learned about from the side? Or are you going to do something to try to preserve the motion over those segments? Well, he's about 7 years post-op, and I chose to do a 2-level arthroplasty on a guy like this rather than a fusion because I think it meets his functional needs clearly better than what we have historically always had to offer patients like this. Let's take a look at this guy, multi-level disease. Most people would probably never operate, and that's probably the right treatment in a guy like this. And I'm not necessarily want to say that doing multi-level reconstructions on these patients is something you do every day, but in very few patients, I think multi-level reconstructions may be an alternative. When you travel to the NASS meeting in the academy, you're going to see all of these different products or go to international meetings. And just like total hips and total knees, all of them have a different axis of rotation, different wear characteristics, different methods of primary fixation, secondary fixations. Some of them go in blocks, some of them go in pieces, and you distract. The technique for each one of these, and subsequently your training for each one of these, is substantially different. But what's the literature on some of this arthroplasty technology? Well, this dates way back to when Terry Marnay, one of the first developers of the Pro Disc, did a whole pilot group of studies almost 25 years ago. They found 64 of the patients, they looked them up, and they had a reasonably good measure of functional outcome. Remember, the bar changed. It's not fusion anymore. It's functional outcome. And then, does motion really make a difference? Well, this study was published in the Spine Journal a number of years ago, and those patients that had motion probably did better than those that didn't, because some of the early arthroplasties never really moved. We really didn't understand that remobilization was the key. There's been a number of evidence in prospective randomized trials, and we'll call some level 1 good evidence on a variety of these technologies. But what I think we learned more from this study and the Pro Disc study like this, we learned more about the functional outcome of our patients with fusions, which was always the control, than we ever knew before, because we always thought the outcome was fusion, not function. So what did we find? And I was involved in the FDA clinical trials for 1-level, 2-level, and the cervical arthroplasty studies. A couple things. These studies are super expensive. We do not have in spine surgery very many randomized prospective clinical trials. In this study, the patient didn't know if they were going to get an arthroplasty or get a fusion until the operation was over. Okay, and we did a 2-to-1 randomization, which was set up by the FDA with a variety of different criteria. All of these technologies that have gone through the FDA for approval have had different measures of success. The only common one is the Oswestry Disability Index. So when the Pro Disc trial that we ran, you had to have 10 measures of success. Someone reads the abstract and says, Mike, we're not approving this because it's only 65% successful. That means that 65% of the patients had all 10 measures of success. Does not mean it was necessarily a failure in the other 30%. So you have to really understand how clinical trials are done, because we don't have many really besides the BMPs and some of the arthroplasties and randomized prospective clinical trials. One of the most common now measure of outcome for function is the Oswestry Disability Index. It's not the best, but it's been the standard for most of these clinical trials. I use an ODI in every patient that comes in for lumbar. At every visit, they filled out so you have some functional measure of how the patient's doing. And what you found at 24 months with the Oswestry Disability Index is about 2/3 of the patients tend to improve compared to that of the fusion group, which is slightly less. And if you look at the reoperation rate, which is always quoted, it appears that the reoperation rate is less with the arthroplasty group compared to the randomized clinical trial groups of patients with a fusion. And the overall success, again, is the number of patients that met all of the criteria at the time of the endpoint, whether that's at 24, 48, or 72 months in these trials. We also obviously asked a generic question, would you have this surgery again at 4 years? And I think if there is a placebo effect, that the patient was angry or pissed off because they got the fusion and they really wanted this really sexy new technology, most of those things I think dissipate after the first 6 months, probably don't go on to the follow-ups at 2 years. Now, how do we do this? I do most of these in a surgery center. We have a stay up to 3 days, so it's like a private hospital. I think they're more efficient. I tend to approach most of these through a mini approach like this from the left, except if I'm doing an isolated 5-1, I always go from the right. Why? Because if I have to do adjacent level, it makes it much easier to operate in the retroperitoneum from the 4-5 from the left side. And we make a small approach like this. This is usually the type of an incision you can get for an exposure. I've went through all of those realms of doing laparoscopic fusions. You saw earlier today balloon-assisted procedures down to really many open procedures where I think we can get a really good exposure just like this for the level that we're trying to operate. I don't like to use Holmans. I like to use frame retractors. I don't like lots of hands in the wound, but that's the exposure that we try to achieve. So how's this done? Well, I'm sorry, let me try this back one. The key here is that we slowly elevate off the disc. And you've got to remember the key is remobilization. Remobilization is the key. If you can't unload the facet joints and remobilize it, the implant will never move again on the case. Let me see if I can get this video to work for you. There we go. And so as I start removing some of the disc, I'm looking how stiff it is. If this is a patient that's 40 years of age and has had 2 previous disc herniations and collapsed, they'll remobilize really easy. If this is a 59 or 55-year-old patient that's had 10-year history of back pain and it's collapsed, it's going to be difficult. You don't always have to take the PLL down to remobilize this, but you always have to release it. The contraction is usually not in the center. The contraction is 90% of the time on the right and the left posterior lateral corners, and that's where you have to release it. Most of the time, the problem is you're standing on the left side and you don't do a great job of releasing that left posterior lateral corner. You have to have a low threshold to go around to the other side and with your eyes get it completely released, as you see right here, to open this up. I know it's released when I can put a curette behind the body of the sacrum and sweep it across, releasing the PLL, behind the back of 5 and release the PLL to truly mobilize the segment. This is an example here. You'll see I put a slight distractor in and open it up, and that allows me to work on the contralateral side and to get a complete decompression on that particular side. Here's what I look for. Unloading the facet joints. Not throwing in the lordosis, but unloading the facet joints. If not, sometimes you'll either break the pars, you'll get a facet fracture, you will give them all kinds of facet pain. You have to unload the facet joint like that, or the implant's never going to move and remobilize. Then you got to center the implant. The spinous process is the worst reliable anatomical structure to center the implant because it's variable. I like to put in a trial like this, and with my eyes I can see the overhang on the left, the overhang on the right, running a line up the side of the trial where it bisects the pedicles, and know exactly where you're going to get it to the sweet spot to put the implant in, because you're going to stare at that for a long time in your career, and it's just like any total joint arthroplasty, you want to put it in the right axis of rotation. You take a collapsed disc like this, you open it up and remobilize it like this, you put in a prosthesis, and then from there we can plop in the polyethylene to remobilize the segment. I think it's a very elegant procedure in the right patient at the right phase. But I collect a lot of disasters, and this is one of them. Don't do it in spondylolysis because they're all going to dislocate. Once you lose a posterior tension band, the implant's going to fail. Here's another classic example. Don't do it in trauma. This patient was referred to me, and you saw the arthroplasty put in. That's the worst treatment for this case. Just because you got a new technology, don't expand the indications. Look at this case. You can see there's a spondylolysis in the back. What's going to happen? You took the anterior longitudinal ligament out. You took the posterior longitudinal ligament out. The pars is broken. The implant's going to fail. This implant, I don't think, was a total disc. I think this implant was a mechanical nucleus replacement, because it didn't have any inherent stability. You took all the secondary stabilizers away, and you think it's going to work. It isn't going to work at all. Same with a case like this. You see a person with a great spine. Someone went to a course. They thought they could put an arthroplasty in, and look how they created a great deformity. So in spine surgery, I think you're either operating on a deformity or you're creating a deformity. So you got to think about it. When I was in my fellowship, I was always trained by Courtney Brown. You either operate on a patient with leg pain and give him back pain, or you operate on a patient with leg pain and you give him back. You operate on a patient with leg pain and give him back pain because you create these kind of problems. So these are all preventable. Anytime someone shows you an X-ray like this and says, "Oh, I did this great job," demand to see the AP. What do you think happened here? Well, I'll tell you what happened here. This side never got decompressed because at the time when they put the trial in, it looked balanced. They never got a release in the posterior lateral corner on that side, and they left themselves with a coronal deformity. What happened in a case like this? They got terrible exposure at the bottom between the iliacs. Either there was a large left iliac vein and artery that wasn't symmetric, the confluence and the bifurcation was a different level, and they got completely off. Those are things that are preventable, but you have to balance all these. I've been doing this for a long time. Now I got to show you mine, okay? I always like to come and show you the worst thing that ever happened to me. When we were doing these disc trials, when we were teaching pro disc after the clinical trials, the FDA required that surgeons had to come and watch a live surgery with me, or Jack Ziegler, or Rick Delamarter, or a guy named Rick Balderson. We were the four of us teaching all of these courses. So I was doing this course, 50 surgeons were in the other room, and my friend Rick Sasso was giving me a hard time, and I put this disc in, and it looked great. I mean, it just looked great. It was retroperitoneal approach, January of 2007. I reconstructed it, lady went home. I went to another course for the weekend, and they called me and told me, "Oh, your patient fell at home and has a fracture." This is a terrible problem. The fracture is 90 degrees in relationship to the keel. What's the name of this kind of fracture? Anybody know? Starts with a P. I know you know, Scott. What is it? Come on. What is it? It's a pincer fracture. A pincer fracture is the kind of fracture where it's a coronal plane fracture of the vertebral body. It's not a burst. And the reason that I just saw a patient like this the other day that had a seizure disorder and had a pincer fracture. The disc gets jammed in between the two between the front and the back half of the vertebral body with a high non-union rate. So this is a pincer fracture, but the fracture occurred 90 degrees in relationship to the keel. She fell down. Amazed me. So what do you do? Anyone have an idea? Well, with great technology, I didn't know what to do. First time I saw this. So I took a picture of it with my phone. I sent it to my buddy in Germany, which is Rudy Bertinoli and Jack Ziegler and Rick Delamarter. I got the same response. Mike, I have no idea, but let me know how it goes. Nobody had any freaking idea what to do. And that's the kind of things that's with today's technology. So what I did, I gave you all kinds of options. You can revise it from the front. You can revise it from the back. You can do it both. You can send your partner and leave town. I was already out of town. So I flew home, and I treated it like I would a fracture. Just like last time, what do you do? I decided I got to stabilize it like a fracture, so I put screws in on the weekend. And then I thought about it for a while. What am I going to do? Well, I decided to open up. She was full of blood. It was about a week later. And you got to figure out how you're going to get this body out. And she had a low confluence and a low bifurcation. So it's not that easy just to go do a corpectomy immediately because you got to operate on the upside and up in between the bifurcation. So what I did is I went in and took the thing out. Remember, the anterior longitudinal ligament is still attached here, and this is broke. The disc is all jammed down in here, so I curetted it all out. Was going to think about doing a corpectomy, but I couldn't get around the vessels, so I decided just to reduce the fragment, lag the screws in the body back intact to create more stability, and then just did a standard A-lift. Now, the beauty is I put this graft in from an anterolateral approach, trying to leave the ALL to give stability of this construct because it was a salvage. One of the worst complications I've had, and this is a patient here, I think immediately, and then here's a 6-year follow-up. So it's not great. Patient came in with back pain and ends up with a 2-level fusion because it broke. But you have to think upon all the bad things that can happen with these kind of cases. And you're operating for back pain and create these kind of problems. I think the complications of lumbar is the wrong indications, poor planning, not doing the right technique, and right balancing it out. Just briefly, I want to comment for a few minutes in the last 10 minutes on cervical arthroplasty. All of these types of cervical arthroplasty have either been tried or currently on the market. There's lots of them currently available. Metal on polyethylene, screw fixation, keel fixation, spike fixation, different axis of rotation, variable axis of rotation. Every one is somewhat different. And we have a lot of information today upon FDA clinical trials. Most of them were randomized against a fusion as a standard control. It's clearly much more accepted because I think ACDNF is more widely utilized by yourself and all of your colleagues and probably anterior approaches in the first place. And they all had different numbers of N in the clinical trials for a variety of reasons, because the outcomes were not all the same. The FDA changes every so often, and some of them had different measures of outcome. But the overall goal is function. It's not fusion anymore like we have with standard ACDNF. And the goal is decreased pain, increased motion, the height, maybe some adjacent level, and I want to talk to you about that, as well as a high recovery. So I think the goal of all of these trials is to increase the motion, increase the function. We follow with a VAS score, a neck disability index. Every patient that comes to my office has a neck disability index if they have neck problem. They have an oswestry if they have low back problem. If you start your practice somewhere and don't follow function, you have no way to really know what your measure of outcome is, especially in degenerative disease. We also look at return to work. We look at patient satisfaction with multi-level reconstructions. We look at SF36, how much medicines they take, and all types of things whenever you do any of these particular technologies and adjacent level disease. I published this in the Journal of Bone and Joint Surgery at the end of 2015 on the 7-year follow-up of the randomized prospective clinical trial. And I think one of the interesting things is it gave us the longest follow-up sum of ACDNFs in a randomized control fashion for function, not just for fusion data. And what we found is I was able to relocate 92% of the patients that was involved in the study at 7 years with on the exact same database that we had from the clinical trial, which I think is quite high. And what we found is there wasn't really any change between ACDNF and arthroplasty, one level in the neck disability index. None of them deteriorated 2 to 7 years. There was no real deterioration in the SF36, as you would expect. Both groups had a high level of satisfaction. But at 7 years in the clinical trial, there was a substantial difference in revision or additional surgery in the fusion group compared to the ACDNF group, actually almost 4 times. And this is what you saw. Actually, this is what happens at 7 years when you look at the one-level fusion groups. On the instance, they needed either additional surgery at the adjacent levels or the index level compared to the arthroplasty group. And if you branch it out by a survival group, you can see the same. So our short-term success is quite high. I think the benefit of arthroplasty in the cervical spine is probably we're seeing it at 5 to 7 years rather than early on because the results are the same. And we find expanded indications. What do you do with this patient? Had a previous 2-level cervical fusion. I did it 15 years ago. And now the patient has adjacent level disease. You could be critical, the plate's a little too long and the fusion is solid. She's got a big disc herniation, a cervical radiculopathy at the level above. How many people are going to treat this with surgery if the patient's severely symptomatic? Okay, most people. How many people are going to do another fusion? Okay, how many people would consider it a motion technology? Why wouldn't you do a motion technology?
It's just a big disc herniation. I think the worry that at our institution would be taking off the end plate,
okay,
being able to drill the osteophytes posteriorly.
But it's primarily a disc.
Yeah.
So I mean, there's 2 options. Both of those will work. So I ended up treating this one with an arthroplasty instead, okay, with a good clinical outcome. I did the first surgery. I had to be responsible to do the second surgery because I had to live with it because that was my wife. I operated on her both times. And I put an arthroplasty in. But I think that's a better alternative in my hands than doing additional surgery. One of the biggest problems with cervical arthroplasty is this concept called the eclipse. What happens is that every time you do an arthroplasty and you want to get a post-op image, this is what it looks like. On the left in the cervical spine, on the right in the lumbar spine. We can't see anything. So I called it total eclipse. After you, I don't know if it's coming through Washington, but in Colorado we have, in 2 weeks, the Great American Eclipse is coming through. So if you don't know about that, that's what I think about when I look at this slide. What causes this eclipse problem? Number one, most of the implants got the ferromagnetic metal, and you get this eclipse or this devoid signal currently. It's this magnetic field gets this area around it. It makes it very difficult to visualize. And this is what you see a lot of times after an arthroplasty, which is the biggest concern I have of all of these types of technologies. Each one's a little bit different. This is the kind of eclipse you see after a Bryant disc, different materials. This is the eclipse if you see after a Discover. It's got a lot less, I think, artifact. Here's the Prestige disc. Here is actually what you see after the Pro disc. It's still hard to visualize. And this is kind of the capture in this study. I think what you can see is the ones that probably have the greatest artifacts is going to be the stainless steel implant because of the volume of the metal and all the things involved. And this is the options. I'm running now clinical trials on the one on the right. And that's what you see after an MRI scan. It's a different material. So maybe now we've learned that disc arthroplasty has a role. It may have a role at 5 to 7 years in improving some of the functional outcomes, but we have to also take a look at imaging. Since these are young patients, we're going to image for quite a while. This is what it looks like when you put it in, so it's a little bit harder for me to get used to. I'm used to looking at the metal and everything. Instead, I'm just looking at the core compared to both of those implants on the other side. What this implant is it's optimized for MRI imaging. It has a low weight anatomical disc. It's called Simplify. I'm running a clinical trial with this currently. And I think the exciting thing, when I ran the clinical trials for Pro Disc and some of the others, it was before the insurance companies really paid attention and most everything was paid for. This particular trial is great. Every patient, the company pays for 100% of the surgery. The surgery, the anesthesia, the facility, the doctor's fee, everything is paid for by the company. So it's a different, because most insurances aren't paying for patients in FDA clinical trials right now. There are problems, and I'm going to close by showing you the same kind of complications I've found now from cervical spine. This is a problem where somebody clearly sized the wrong implant. This isn't just a implant, it's too big, it wasn't a good release, the implant dislocates. These are technical issues by doing the wrong surgery at the wrong phase with the wrong technique. Here's another one where they did the wrong Implant Preparation. And look at the subsidence you see on the one on the left as well as the one on the right side. This is balance. This is a lady that had a fusion and then she went to a surgeon and he put 2 unconstrained disc replacements and you can see how it created another deformity. I ended up taking both of those out and fusing them. I could have thought about putting in a semi-constrained device, but I don't like to get away with things when I see disasters like this, so I think you have to reconstruct it. But you have to look that this was probably the worst treatment. All of these are bad balances. You see how they remove too much bone. Some have subsided, some have collapsed. Teeth have gone down into the vertebrae. Here's one that's in kyphosis, the one on the top left with all that osteolysis around it. All of these are just terrible situations from a very simple technology that probably was either applied wrong or the poor judgment. And sometimes you get subsidence. This is a physician that had this done because he demanded to have surgery. They put a tall prosthesis in, burred all the spurs away just like he talked about, and they end up with a terrible functional outcome that required revision. And sometimes you see patients with instability. I did this patient a long time ago with a 2-level arthroplasty. He fell out, he was in a car accident and had bilateral jump facets. Another bad example of implant, I'm just going to show, I have just a couple. And sometimes you have to pick the right technique at the right phase of the disease. This looks like it's going to work, and look at the coronal plane, but look what happens shortly thereafter because they burred too much of the bone away. So in summary, I think arthroplasty does have improved outcomes. It does have maybe a little less rehab. It does retain motion, and it is a new philosophy of care in lumbar and cervical, but requires a lot of technique to be able to get a good outcome. Thank you.